everyone. Welcome back to another segment of Breaking the Chain with Caitlin, a digital story Vodcast. Each episode, we explore unique roles of various healthcare workers relating to infection prevention and control practices. I'm your host, Caitlin Cosgrove, and today we'll be talking about infection prevention and control in long-term care. Now it's time to welcome our guest, Michael. Hi, Michael, and welcome to the show.
Hi, Caitlin, and hi, everyone. Thank you for having me here. I'm very glad and excited to be here and share my experience and my knowledge with infection control in long-term care. I work with the City of Toronto, where we operate 10 long-term care homes, and my role is the manager, advanced nursing practice. So in that role, I would oversee the nursing program, the portfolio, the education, the research, and that will include infection prevention and control.
Okay, thank you so much. That's a good prelude to my next question. So what is your role related to infection prevention and control practices in long-term care?
Yeah, so again, my overall goal really is to provide leadership in the development, the administration, and really the evaluation of infection prevention and control for the 10 city-operated long-term care homes. And more importantly, it's really to provide expert knowledge and practices, leading practices, and newly practices in this year as well, to advance nursing care practices in long-term care homes. So that includes IPAC practices. A part of my role as well, and in achieving all of these things I just mentioned, is really collaborating with each home level nursing leadership team. So in every long-term care home that we operate, there's another set of leadership team there, right? So it's very important in my role to collaborate with each of the leaders in that home. And I'm not just talking about the nursing leadership team, I'm talking about environmental service leaders, food and nutrition leaders, physicians, resident services team as well. And the reason why collaboration is so important between those disciplines is I want to make sure that there's accountability for the implementation and the sustainability of clinical IPAC practices. And of course, to identify any areas of opportunity for improvement, for advancing nursing care excellence in infection control.
Wow, thank you so much for sharing. You're right, there's a lot more that goes into collaborating and working together. And I know you talked about evaluation of like the 10 different long-term care homes that you work with. What would be an example of like an evaluation you would do?
Yeah, so particularly with infection control, right? A lot of evaluation will be a lot of audits, right? So we've done a lot of audits in the home. So we would audit certain things. So we would audit the environment, the physical environment, the cleanliness of the environment. We would be auditing hand hygiene audits for all the healthcare workers working in that long-term care home. We'd be auditing, the reprocessing of medical equipments. How often and how clean are the medical equipments used between residents, for example? We'd be auditing personal protective equipment practices, donning and doffing, right? And with those audits will come, different types of data and numbers to help guide whether what we're doing well and what we're doing or what we could do better in, right? We also evaluate and trend and analyze on a monthly and quarterly basis on the number of infectious diseases that occurs in that long-term care home. So you may have known the definition of nosocomial infections. So these are hospital-acquired infections that every healthcare institution needs to be tracking. So we pay a heavy focus on that because the stricter surveillance we can provide and the earlier detection we can do, the more efficient we can contain not just COVID-19, but any infectious disease that enters at home. So what I have spoken to is a very clinical evaluation of infection prevention and control. And I can tell you that there's actually a lot more than that.
Wow. Wow, there's so many different components, like even like the PPE donning and doffing that, and like all the data, like documenting all this is so important. And as a nursing student myself, we have the opportunity to go to different clinical placements. And I know the one question that a lot of students ask are, how is infection prevention and control practices in long-term care different from acute care hospital settings?
Well, infection prevention and control practices are not that different versus the acute care hospital, right? I mean, we still do safe practices in personal protective equipment. We still have almost the same donning and doffing procedures, perform hand hygiene for 15 seconds, even the cleaning and disinfection of the environment and medical equipment, detecting, surveillance. That's pretty much all the same, right? But the only difference really is I would say probably the most important is really the culture. It's the culture that's different, right? I mean, long-term care is really the resident's home. It's a home-like environment. It's not an institution environment. In acute care, people go to the hospital to be assessed, treated, monitored, and discharged home. They're cured, right? In long-term care, that is their home. That's where people get discharged to. So our setting and our environment and our culture is very different from acute care hospital. For instance, during this pandemic preparedness a year ago, pandemic preparedness, probably in the month of January, February, or March, it really favored the acute care hospital. So if you look back almost over a year ago, it really did focus on preparing the hospitals for this pandemic, right? Nearly all effort was diverted to create, surge capacities in hospitals to ensure that there's enough ventilators and space in the ICUs, right? And during that period of time, it left most nursing homes unprepared for this pandemic. So, I mean, comparing to the hospitals, dealing with infectious disease and personal protective equipment was not as relevant as it was prior to the pandemic, comparing to the hospital, I'm saying, right? But in terms of, PPE practices, cohorting residents, ensuring that residents with COVID-19 are in a different area than all the non-symptomatic residents, even staff. We had to cohort staff too, right? So staff who are looking after residents with COVID-19 had to stay in that assignment for the next week or for the next month, right? There was no more cross boundaries. So that's what I'm trying to get at, right? The environment and the culture was very different. In hospitals, right? You only work in one unit. You either work in the medical surgical unit, you either work in the emergency department, and you're in that unit. In the long-term care homes, you could work in many different floors, right? Because you could work on the first floor, second floor. There's no different department like in the hospital. So cohorting was a huge change for our home. Meaning, what do you mean I can only work on the fifth floor? I always usually like to work on the second. I usually like working with this resident and etc. Because in long-term care home, we do a big emphasis on continuity of care, meaning we really like our residents to have the same assignment for the majority of their stay in long-term care, right? While in hospitals, you could have a different set of patients every day. So cohorting and isolating residents in the same assignment was a big change too. So
wow, yeah. Definitely a big culture change. And with that too, like how did I guess like PPE, like the need for PPE change with COVID-19?
Yeah, so that's a great question. So with the use of PPE, it did change for sure, right? And the reason behind that is, with COVID-19 itself, right? COVID-19, as we all know now, it's highly contagious. There's a long incubation period of 10 to 14 days, and it can affect people that have no symptoms, right? The spread was invisible, right? Now, imagine back in the early weeks of the pandemic, before anything of this was widely known about asymptomatic spread, etc., right? That this COVID-19 virus can spread in and back of our nursing homes as families and visitors and staff were coming in every day, not knowing about this, how contagious this virus was. I'm talking about January, February, and March 2020, right? So, and by the nature of their work, that the personal support workers, nursing, our housekeepers, everyone, the nature of their work, there is a high risk of infection given the unavoidable close contact between staff and residents, right? Because the relationship between staff and residents, they're really close. It's their home, right? That's, you want to make them comfortable. Sometimes you hug and you touch, therapeutic touch, and all these things, right? So, and again, even prior to the pandemic, long-term care staff were not as accustomed to personal protective, not even equipment, but practice compared to acute care, for instance. It's not like every day in long-term care staff, had to put on their gown and their gloves every day, let alone every week in long-term care. While when you go to a hospital or a complex care setting, there may be some patients there that are isolated on contact and droplet precautions, and you should know in and out from your orientation how to do it. But in long-term care, I'm not saying that we didn't do much of it. I'm just saying compared to the volume of PPE practice, it was much lower than in acute care. So that being said, it just wasn't that much prior to the pandemic. So therefore, now everything that we've gone through, that has gone 360, right? PPE is in everyone's mind now. Fortunately enough, working with the City of Toronto, we had no issues with PPE supplies.
Wow.
So because we are with the City of Toronto, we have our own central supply chain. So even in the early weeks of the pandemic, we weren't short of PPE, and that's a big blessing being part of the City of Toronto. But I can tell you the big step was the education, the personal protective education. Having people wear PPEs only in the room, doffing before they get out of the room, donning before they go into the room. Those were all very new things. And maybe it's not new things, but very refreshers, right? We had to give a lot of refresher educations to them. So with that being said, basic infection control practices, we weren't really accustomed to prior to the pandemic. And that makes sense because we weren't dealing with so many infectious diseases compared to what a hospital would, right? So therefore, moving forward now, we're focusing a lot on infection control practices and really the sustainability of it. How do we develop a sustainable education on IPAC related not only to personal protective equipment, but strategies for clustering and isolating residents, clustering staff, infection surveillance strategies, early detection, even screening now. We have a really tight and strong screening process before you go into long-term care home. Rapid antigen testing. So we are doing a lot of sustainability projects currently right now. How do we sustain best IPAC practices even when this is all over?
Wow, that's really interesting that now there's all these different strategies that are added. And I feel like too, going back to how you said that the culture changed where especially these are people that live here and that touch is important. And that when you build those relationships with clients before the pandemic, hugging your patient was common. And now you're right. It's this 180 shift of okay, now we have to have PPE. Now you have to remember to don and doff. So to end off, what are some clinical tips you can share with students regarding infection prevention and control practices?
Yeah, some key clinical tips I can provide to the students and everyone else is, many things. So the first is to ensure that you're all practicing standard precautions for the care of all the residents at all times. And so in order to do that, you may also need to understand something called point of care risk assessment. So if you were going to a long-term care home that is not on any type of outbreaks or is not on any contact droplet precaution, I think it's important that we understand point of care risk assessment. For example, based on your risk assessment before entering, the resident's room or their environment, will you need any PPE despite not being on any type of precaution? So, for example, if you know you're going to be doing, any urine or sorry, handling urine, handling stools, or even, handling wound drainage, especially in an environment where there's a pandemic, um, then I would warrant staff wearing gowns and a glove because you may be at risk for bodily fluid splashing at you, right? So you can still wear a gown and gloves for those instances, even though you are not entering a room under droplet contact precaution. Okay. Um, that being said, residents aren't used. They are not used to staff wearing PPE entering their rooms, right? Remember, this is their home, and they're used to seeing their caregivers, their personal support workers, their nurses, freely entering their room and taking care of them. So it's also very important to, remind the residents not to feel offended or afraid if staff do use, personal protective equipment when providing care. It's important to explain to the residents and their families the standard precautions for everyone. Okay, so that's clinical tip number one. Uh, Clinical tip number two is probably the most important one. Practice really good hand hygiene. Practice hand hygiene when moving among residents and from soil to clean spaces. Um, and when you do enter an environment in a long-term care home, you want to make sure that it is okay and that the culture is easy for people to ask each other, have you cleaned your hands? Have you washed your hands? Um, Maybe from some of your experience, uh, uh, staff don't take too well with these type of questions because it may come across as uh, I don't know, defensive or anything. But I think we need to start moving to a culture where it's okay to say, have you washed your hands? Have you cleaned your hands? So want to make sure you enter an environment like that, and suggest quality improvement initiatives. Right? We love quality improvement initiatives in long-term care. So if you're in a placement, maybe there's some sort of QI project you can do with hand hygiene, right? Um, Another important thing too, the third one is really observe the standard precautions of not touching any bodily fluids like blood or mucous membranes or wounds with your bare hands, and then not letting these hands and fingers touch your face or touch your skin or your clothes. Okay, so again, I think when you guys are placed or if you guys enter long-term care as an RN, I think your duty is to encourage everyone, residents, visitors, family members, healthcare workers, to clean their hands before they eat and after they use the washroom, right? And clean their hands before and after each touch of an object, for example. The fourth clinical tip I'd probably say is it kind of relates to the first one I gave you, but really using personal protective equipment safely, especially when you're going to come into contact with blood, body fluids, or non-intact skin, right? In addition to ensuring you're using really good PPE technique, uh, remind your team members, right? Remind people around you to use PPE whenever they might come into contact with another person's blood or body fluids, right? And again, explaining to the residents that PPE, is a standard precaution used to protect everyone. Uh, um, advocate for your fellow colleagues, right? Ask for more PPE when supplies in your work area are running low. so that everyone has access to PPE at any time and at any day. Encourage your colleagues, right? Encourage the staff there to change PPE if they touch a contaminated area, or if they move from one contaminated area to a clean area, or from caring for one resident to another, right? Ensuring that the long-term care home you're entering has that culture that it's okay to say these things. And another clinical tip too is practice good environmental cleaning, right? So different long-term care homes actually have chemical products and practices. So I would ask the facility that you are being placed at for training on how to use cleaning chemicals, and ensuring that you're choosing the right surface appropriate product, right? Like the right low level disinfectant. So yeah, ask your preceptor, how to alert residents and family members to use, even alcohol-based hand wipes to help keep their own rooms clean. Because some residents and family members have their own disinfectants that they like to disinfect their surfaces as well. And then last but not least, one of the major changes that we all had to adapt to in long-term care was being familiar with how to practice isolation for residents. I mean, prior to the pandemic, we didn't even like that word, isolating residents, right? We don't like to isolate residents. But with this pandemic, we all needed to be familiar on what that means. Okay, so be familiar with isolation practices in that facility, right? So for example, when a resident is colonized or infected with germs that may be spread to other residents, it may be necessary to move that resident out of their room, and think about it, out of their room that they've been living for years in. Okay, so it may be necessary to move them out of that room to reduce the chance of spreading the germs to the roommate, right? And the goal in long-term care facilities during a pandemic should be to place residents in rooms with the lowest risk of infections, spreading germs. So private rooms are the best way to do this. If there are no private rooms, the next best option is to cohort residents, right? Group residents together if they have the same germ, for example, COVID-19. So when cohorting is not possible, you're going to want to place residents with residents who are at low risk. So, and while you're doing all this, you need to be coordinating with the family members and the residents. So it could be very challenging at times, but it's also very good learning, right? Logistically and these isolation practices, and it's good IPAC practice for you all to know and get familiar with. Okay, and they do these type of things as well in acute care hospitals as well. So, so while you're understanding isolation practices, you'll also learn really good communication styles and tips to families and residents, right? It's like, so for example, you're going to be able to learn to explain to the resident why they're being moved into isolation in a nice person-centered way. You're going to be communicating to the resident and the family why they're being moved into a different room, right? You're going to have to learn to have those difficult conversations. Okay. Last but not least, you're going to ensure and learn the plan of care, right? Plan of care is documented on the daily assignment sheet, and that all staff are aware of this, isolation practice in the resident's care plan. And that is it. I think that's the most high-level clinical tips I can give you all.
Wow, thank you so much. Those are a lot of amazing tips. I think the key takeaway I got from that is, like you said so many times, communication, whether it's communicating with the residents and their family members about isolation, or whether it's communicating with other staff members and residents about PPE, or did you wash your hands, and not being afraid to advocate for residents and their family members and all the staff. So unfortunately, we've reached the end of this episode of Breaking the Chain with Caitlin. Thank you to our guest, Michael, for sharing your experiences working in long-term care. And thank you to the listeners for tuning in. Until next time.
Yes, thank you. Thank you for having me. And best in luck with all your future endeavors, everyone.